Hi, good evening. Can you listen to me? All right. Can you see the presentation? All right then, so let's begin. Today's subject will be nutrition and surgery. Although you can see a very long presentation, it is rather simple as we can divide nutrition into enteral nutrition and parenteral nutrition. Briefly, there will be a new activity. I will upload a presentation with 5 or 6 clinical cases in which you would have to decide what type of nutrition should the patient be receiving in order to start feeding him. So the aim of nutrition support is to identify those patients who are at risk, especially in the surgery board, and to prevent malnutrition and to meet their nutritional requirements. So we have to evaluate if the patient has an adequate nutritional status. If not, we have to ask ourselves if the GI tract is functional. If not, well, we have to establish in a short-term period whether he is at risk or to develop a malnutrition, and we have to decide to start parenteral nutrition right away. If we have a functional GI tract, but we are waiting until the patient can receive further feeding, then we wait and we start nutrition right away. So the main thing is that after surgery, we have to establish how long the patient is going to be on a fasting state. And after that, we have to begin as soon as possible enteral feeding. If we cannot use the GI tract for any number of circumstances that we will be seeing further ahead, then what we should do is to establish when to begin parenteral nutrition and what route would be the best for this patient. Now, the metabolic response, as you can recall, within 12 hours of fasting, the insulin level will will diminishes, and the glucagon level will rise. And the metabolic pathways, they start switching to gluconeogenesis after 24 hours or 72 hours of being in a fasting state, and therefore lipolysis take place, inducing ketogenesis, which is toxic for the brain tissue. Now, on sepsis is the same thing. The increase on the counter-regulatory hormones such as glucagon and cortisol and adrenaline, they are released because the energy requirement increases. Therefore, it causes an insulin resistance, and this in terms, it could lead to a malnutrition if we prolong this thing. So the energy requirements, as you can recall, is 1 gram of carbohydrates provide about 3.4 calories, and 1 gram of fat provides about 9, and protein about 4. So in an average adult means that he needs about between 30 to 35 calories per kilogram per day. So we have to keep this in mind, especially in those patients that we're going to have them to be on a fasting state longer than 7 days. Now, what we have to do, this is very basic. You need to ask about the feeding status of the patient. Of course, you see his physical examination. It is obvious when somebody is overweight or obese, and somebody who is very lean, very thin, and or somebody that it is underweight. You see the skin folds over the biceps, the triceps, and you can take labs in order to assess the protein, the albumin, and so of a test. But in general, you can make a quick assessment by asking the nutritional history of the patient, and if he had any weight loss or any weight gain, and of course the physical examination. The MUST tool that you already know is the body mass index, and if we are meeting a patient that has lost 36 in the last half a year, experiencing weight loss, this is an alarm sign. So we have to be very aware of that. So after that, there are serum markers that will tell us if our patient is falling into a malnutrition state, such as albumin. If you see a patient that has lower than 3 of albumin, or a transferrin, which is the albumin transport less than 200, this patient is failing to be on a nutritional support. That means that we have to keep our efforts in order to feed him better. Otherwise, he's going to start this gluconeogenesis cycle and to form ketone bodies and to begin to have muscle wasting. So this is very important for you to remember. Nil pros, as you can recall, is nothing by mouth. Your patient, any patient, can be on a fasting state up to day 7. After day 7, you have to start nutrition, whatever the cost. You have to decide whether it's enteral nutrition or parenteral nutrition. By day 7, you have to decide right there if your patient is starting on nutrition. So enteral nutrition means that we will be using the digestive tract, all right? It's not the same as oral feeding. Enteral nutrition means that we're using the digestive tract. Up to what point are we going to be using it? Either any segment. We can use it up in the stomach, in the jejunum, and that's it. And parenteral nutrition means parallel, another way of different from the digestive system, which is intravenously. And what do we measure in this type of nutrition? Well, you're not going to do it per se, but you have to be aware that the patient will have to meet the nutritional requirements for his weight and his clinical or surgical condition. That means the diets are composed of water, of course, calories, protein, sodium, potassium chloride, all the electrolytes needed, and some special amino acids depending on the case. So here goes. Enteral nutrition, that means that we're using the digestive tract. We can use it through a nasogastric tube that goes into the stomach, or a gastrostomy tube that goes directly into the stomach, or a jejunostomy tube that goes directly into the jejunum, or we can use a nasojejunal tube that goes from the nasal cavity, passes through the esophagus, the stomach, and ends up in the jejunum. Enteral means all these routes that can be used depending on the patient's circumstances that we'll be seeing further ahead. And parenteral nutrition, that means that we are giving it through the vein, and we have two types. It is a peripheral parenteral nutrition. That means that if we use a peripheral vein, and that will depend on the osmolarity on the nutrition. And total parenteral nutrition over here, we can use this only through a central venous catheter. All right, only through central venous catheter. So enteral nutrition is what you already know as oral supplements. You can give them through feeding tubes such as gastrostomy or nasogastric tube or jejunostomy tubes. And of course the gastrostomy and the jejunostomy, they are performed on the operation room. You don't have to know the techniques, but you have to know where they go. So this is enteral nutrition, as you already recall. The Ensure, it provides calories as well as proteins. All right, you give this in patients that they're not feeding quite normally, or they have, for instance, they have trouble chewing, or they are very weak, and you have to supplement other aside from the food. You give Ensure. And well, you start it with a little sips, because it can cause diarrhea or bloating, abdomen bloating, or gases and so forth. This is one type of enteral nutrition. You can give Ensure, of course, through a nasogastric tube or through a nasojejunal tube as well. Now the tube feedings is you administer your enteral diet through the tube. I'm going to say this again. You don't have to know the techniques, but you have to know they exist. So there's the insertion, the nasogastric tube. You're going to do this on your surgical classes. If not, please let me know, and I'll make sure that you learn this. The gastrostomy is a tube inserted, this is the technique, this is a tube inserted directly into the stomach. So the PEG technique is a percutaneous gastrostomy, percutaneous endoscopic gastrostomy, which is the best technique used. And you can see it goes directly into the stomach. Now this picture over here shows that there's leaking of the gastric content onto the abdomen, and you can see, of course, the gastric content. It is chloride acid, and it is burning all of the skin. So we have to be very careful on these patients about that. And this is the procedure. By endoscopy, somebody realizes performs the endoscopy, and the surgeon cuts off the skin until he arrives into the stomach. He sees the light where he has to cut off, and then he cuts off the stomach. He opens it and introduces the gastrostomy tube. He inflates the balloon, and then he attaches these to the aponeurosis of the stomach, and that's it. You have your gastrostomy tube. When are we going to use this? For example, in a patient that had a lesion into the esophagus, for instance, he ingested acid. All right, he burned his esophagus, and he cannot eat anymore by mouth. So you have to start on nutrition, and you know that this nutritional route is going to be a long-lasting one, because that patient won't be able to eat ever again. Another situation is those patients that have cerebral palsy, and for some reason, if they eat, they can have a bronchial aspiration, and in order to avoid that, we perform on them a gastrostomy tube, and that's the way we feed them. Questions so far? All right. The jejunostomy tube is the same thing as in the gastrostomy, but in the jejunum, it is performed just about, not the same, it's not through endoscopy. These patients, we take them to the operation room, we open them up, we locate the jejunum, we open it, and we introduce the tube, and then we close the abdomen. When are we going to use this? In those cases that we are not able to use, we have to bypass, so to speak, the stomach absorption. What cases are these? For example, if a patient had multiple gunshot wounds in the upper abdomen, and he had lacerated the duodenum and the stomach, then we won't be able to use those in quite some time, for at least 15 days or even longer than that. So we need to feed our patient. How are we going to feed him? Well, through a jejunostomy tube. Other circumstance that you may encounter is those patients are quite obese, that were subject to perform a gastric bypass, and they get complicated because there was a leak in some of the anastomosis. Well, we cannot feed them anymore through the stomach, but this is temporary, so we have to feed them through the jejunum. So the main point is that we have to assess what level of nutrition is suitable for that patient. So if we cannot use the stomach, we have to move further. All right? So if we cannot give nothing through the mouth, because let's assume that the patient had a maxillary surgery because of a bone fracture, that patient won't be able to chew for a long time. So we have to feed him either through a nasogastric tube or a temporary gastrostomy. And if we cannot use the esophagus because it got burned or it got ruptured, then we have to use the stomach through a gastrostomy. It is like if we don't use the first, then we use the second, then we use the third, right? That's how it works. And if we cannot use either of these because it's not advisable, such as in, let's say, pancreatitis or short bowel syndrome, or a patient with a gastrointestinal fistula, then we use parenteral nutrition. So what are the complications? Well, that we inserted the tube wrong, that the tube gets blocked or it gets broken. It is, or we have some erosion of the skin, as you saw before with a gastrostomy. We can have diarrhea or bloating or constipation. Metabolic, we may encounter some electrolytic disorders. It can get infected, and well, that's pretty much it. We can rarely see a perforation, but it may happen. And the advantages is that we keep using the digestive tract, So we preserve the immunological function of the gut. It is less expensive than parenteral nutrition, and it can be easily monitored. That's the advantage. Now, it is contraindicated in a patient that has paralytic ileus, that we are in a phase of a patient that is obstructed with peritonitis or with a gastrointestinal hemorrhage, or in severe shock. Of course, that is not going to be our priority in there, so we avoid starting enteral nutrition. How are we going to choose our formula? It will depend on the patient and the osmolarity and the specific metabolic needs, but most of all, it's going to be suited for the patient needs. If the patient needs to have a nutritional support to counteract his malnutrition, then it'll be a nutritional support that will be rich in proteins. We could give it in bolus rapidly, or intermittent every other hour, or cyclic, usually a pump during the night, or continuously as a gravity drip. What do we have to check? Well, we have to check every third day approximately. We have to check the electrolytes, the blood sugar, the nitrogen balance, and the protein levels. And we have to check that the patient is stable. He doesn't have any fever. He doesn't have any hypertension or tachycardia. We have to monitor these patients very close. They are different than the ones that are already eating by mouth. So we have to not every hour, but every day, and make laboratory testing every third day. Now, the parenteral nutrition goes into the vein. The nutritions, they do this. It is a pre-digested form of feeding. It contains amino acid, dextrose, lipids, and electrolytes, and so forth. So it will depend on the osmolarity of the solution that we're going to choose the route. Either total parenteral nutrition, it goes above 1,000 milliosmoles per liter. That means if I have a solution on this osmolarity, I have to use a central venous catheter, and I use a triple lumen because on one I give the parenteral nutrition. On the other one, I give the solutions and medications, and on the other one, I can withdraw blood to perform continuous laboratory testing. The advantages is that it provides everything, and we can feed the patient whenever the digestive tract is not able to be used. I'm not going to ask this. We use peripheral if it's less than 1,000 milliosmoles per liter. And I'm not going to ask this, but it is important for you to know this. For instance, we have a normal calorie spent every 24 hours according our weight, according our gender, and according our grade of activity. It's not the same if I run every day about half hour that comparing to a person that sits 24 hours a day playing video games. he won't be spending as much calories as a person that runs. Well, the same goes for diseases. A patient that is at bed rest, it has a activity factor, is what nutritionists called it, or disease factor or thermal factor. So if the patient had surgery or is in sepsis, as you can see, it increases the disease factor of and therefore it increases his metabolic needs. Also, if your patient is in fever or is under under artificial ventilation, is going to increase his metabolic rate, therefore his caloric needs will increase. Is this clear so far? So I'm not going to ask this, but it is important for you to know it. So if your patient is with fever for many days, aside from being dehydrated, he's going to start losing proteins because his metabolic needs will increase. Therefore, his caloric expenditure will increase as well. So there are several formulas. You already know the mixed solution, that is a saline solution combined with dextrose solution, and that is, we give that in order to give the patient a bit amount of calories. Of course, glucose solutions cannot be used in patients under severe stress. So if you are on a scenario performing reanimation of a patient, you're not going to give dextrose. As a matter of fact, the nutritional status will be the last thing you will have to worry. And for instance, if you're in a public hospital, the parenteral nutritions, they are standards. You can ask for one that is already been fixed with a lot of amino acids. You can ask for another one that it is rich in lipids, or you can ask for some solution that is rich in dextrose with amino acids or combined. Now, on private sector, these parenteral nutritions, they are made according to the patient needs. That's why they become so expensive, because they don't have it just like a milk that is already there. They have to put all the ingredients together to make a special formula that is suited just for one patient. You're going to see that when you arrive to hospitals. And we have here solutions that are rich with amino acids. And amino acids will become essential, especially to those patients that are under severe stress and they are with malnutrition status, and we need them to recover as soon as possible. So one of the amino acids that it is important in the digestive system is glutamine. Glutamine improves the survival in the stressed and sick patients, and it improves the digestive function of the mucosa. And arginine, it improves the immune function. So we use this especially in patients that are coming out of a septic shock or had a great abdominal surgery and something like that. Well, if we don't have that, you can find these on public hospitals, just plain albumin, and there's no, well, that's pretty much it. This is how they design a parenteral nutrition. I'm not going to ask this. There are different kinds of solutions. And the complications of having a parenteral nutrition. All right, we have immediate complications within the 48 hours, which is mechanical, and these are because of the placing of the central venous catheter, such as hemothorax, pneumothorax, embolism, blood loss, hemorrhage, and so forth. And we have the metabolic complications such as fluid overload, hyperglycemia, and abnormalities on the electrolytes. What we have to do after we place the central venous catheter, always remember these, always before starting your parenteral nutrition, you have to check your chest X-ray and make sure that your catheter is placed on the right place. Otherwise, if you don't have any chest X-ray available, you won't start parenteral nutrition onto a central venous catheter. This is very, very important for you to know. Now, in the first 2 weeks, the catheter may get displaced or it may get occluded, and it can get infected, and we have to be very aware of this because once it gets infected, we have to remove it right away. All right, this is support that it got infected. This is not for nutritional support, but you can have a look at that. This is for chemotherapy. Of course, there's purulent drainage coming out of it. This is very, very infected, dirty, and you have to remove it right away. And if you see this reddish thing, erythema, edema, and the patient start having fever, and you can see the exposed port, you have to take it off right away, immediately. And later, the complications are tear of the catheter or thrombosis of the catheter, and tunnel infection and sepsis. So you have to check that very closely, especially on hospitalized patients. And, well, there are complications. I'm not going to ask about the complications, but you have to be aware that hyperglycemia, it is a very common complication, such as fluid retention. And if we're not aware of that, and especially electrolytes, we can end up in cardiac arrhythmias and death. So patients on parenteral nutrition have to be monitored very, very closely and ask them almost one day on and off laboratory testings. And well, we have to check them every day, vital signs, weight, the site care, the dressing change, everything. And special considerations are, of course, in burn patients, short bowel syndrome, which is very complicated. We're not going to see that. And gastrointestinal fistulas. This is where we use parenteral nutrition. The cases where we use parenteral nutrition. But that's it. Any questions? No questions? Well, thank you for being here. As usually, this will be recorded for you to to download and check it later. Thank you for being here. Have a great weekend. Bye-bye.